Again, this is the second part on the water and sodium homeostasis talk. I'm going to discuss with you some pathophysiological aspects now, mainly on hyponatremia. I have to remind you that this is the second part of two other parts. The first was the basic physiology, and the next one will be a talk on hyponatremia. So just let's talk a few minutes on hyponatremia and the diagnosis of this quite difficult disease. In ancient times, and ancient times is in this case already 1999, where this was more or less what was said to be done by the Atlas of Diseases of the Kidney a few years ago. It is ancient because we all know in the meantime that this approach doesn't work that well. The first step in approaching hypotonic hyponatremia was the assessment of volume status, and we all know this is already very difficult, and we all know also that you can be perfectly hypovolemic while having edema, so it's a very difficult diagnosis to make. And the second split in this flow chart, or the decision chart, was the measurement of urinary sodium, where there was a cutoff of 20, which is of course a very decisive and therefore not so accurate number. So in the meantime, I think we updated the diagnosis of hyponatremia a little bit, and I think the approach I'm going to propose to you is a little bit more workable in the critically ill patient and in the patient that is presenting himself on the ward or on the emergency department. So let's take a few steps here. The first step is the step before we are going to turn to the lab diagnostics. It is start with your story, start with the medical history. Is there pathology that is typical for hyponatremia by having an expanded, a need for an expanded extracellular volume, like heart failure, liver failure, and some kidney diseases? What was the fluid and food intake in the last couple of days? What are the drinking habits or the alcohol or beer drinking habits of this patient? Is there a reason to suspect volume depletion? Because in some patients with volume depletion, there is no hyper but hyponatremia. Is there medication? Especially, are there medications that are associated with the syndrome of inappropriate ADH secretion, or is there diuretic use? And of course, perform a physical exam in which there is specific attention for the nutritional status of the patient, for edema, and for dehydration. Especially important is the presence of symptomatic hyponatremia, because this will guide our treatment, or the seriousness of or the urgency of our treatments. So how long these symptoms are present, and are there symptoms present, is a very important question in view of the treatment of hyponatremia. Then we are going to do some investigations in the lab. And the first one is classically the one to exclude hyperosmolar hyponatremia. This is actually not pseudo hyponatremia, but true hyponatremia. It is there because there is an enormous amount of other osmolar substances that are present in the blood, and the main example is glucose. We see this mainly in diabetic ketoacidosis and in the hyperosmolar hyperglycemic non-osmotic coma, and we have to admit that these diagnoses are mostly made quite easily before a workup is needed on hyponatremia. The reason is there is a dilution of the sodium because of the presence of this osmolar substance like glucose, which sucks out the intracellular volume and dilutes the sodium in the plasma. In this case, there will be no symptoms of increased cerebral intracellular volume. So there will be no edema, of course, responsible for these symptoms. Another thing is that we should exclude pseudohyponatremia. This is actually a lab artifact. It is caused by this technique called indirect potentiometry. The reason is that in this technique, some water is added to any tube that has to be analyzed. And when there is a large solid phase, for example, due to hypertriglyceridemia or due to hyperimmunoglobulinemia, what a word, we will dilute the remaining water phase, and there will seem to be a hyponatremia, which is of course not there in reality. The second step is an important one, and now we are going to see whether there is ADH present. And I refer to my talk on basic physiology of water and ions earlier. It is important to see to measure urinary osmolality because it is a direct measurement of ADH activity, ADH or vasopressin. And we know that the more or the higher the plasma osmolality is, the more ADH will eventually be secreted. So if urinary osmolality is adequately suppressed, and we can call this, this number below 100 milliosmoles per kilogram, we know that there is excessive water ingestion. So the hypophysis does what it has to do. It will cut down on ADH activity. Urinary osmolality is low, but we overflow our system by excessive water ingestion. There is a small side syndrome, it's really common actually, but it is actually exactly the same like beer potomania and tea and toast hyponatremia. These are two variations on the same topic. The only difference with pure polydiptic hyponatremia is that now these patients do not ingest enough solutes to be able to produce lots of urine. So actually, when a perfectly normal person ingests large amounts of free water, he will be able to dilute urine maximally, and he will be able to produce 10, 12 liters of urine before hyponatremia will ensue. But in these beer potomania or tea and toast hyponatremia patients, this is not the case. These patients can only produce 4 to 5 liters of urine before experiencing already hyponatremia, just because you need some solutes, you need some urea and salts to be able to produce enough volume and to dilute this amount of urine. This is step 2. The second part in step 2 is when there is a relatively high urinary osmolality. Clear number is when urinary osmolality is higher than plasma osmolality. Now we know that there is certainly ADH available. There is a gray zone of urinary osmolality when it is between 100 milliosmoles per kilogram and the plasma osmolality. But the most easy thing is to see that there is a higher urinary osmolality than there is a plasma osmolality. Now we know for sure that there is ADH activity working in this patient. How to interpret the patient with high urinary osmolality with hyponatremia? Now we know there is ADH, and now the question is, should there be ADH? And now we are going to assess whether there is or not hypovolemia. And the best measurement, and I again refer to my first talk, the best measurement is to see whether there is aldosterone working here, and the best measurement in the urine or in urinary biochemistry to see whether there is aldosterone present is the measurement of urinary sodium. When this urinary sodium is very low, of course, in the absence of chronic kidney disease or diuretics, we know there is aldosterone working. And I think we can call this easily the syndrome of appropriate ADH secretion. There is ADH because there should be. And I refer again to the graph there in the left lower side of the slide. We know that the body will prioritize hypovolemia over hypoosmolality, and even when there is a hypoosmolality, in the case of true hypovolemia, it will try to recover some of the water that will otherwise be lost, and now we will see a correction of this hypovolemia at the cost of an hypoosmolality or a hyponatremia. A remaining question there is whether this hypovolemia should be is a true hypovolemia, just like in GI tract losses or skin, sweating, burns, or third spacing, or whether there is a false hypovolemia where the body just interprets there is a problem, just as in heart failure or in liver failure. These are the two most common examples of SAADH due to hypovolemia. There is another situation where urinary sodium is not low but high, so there is no aldosterone present, so there is no true measured hypovolemia. So now there is a problem of there being there the presence of antidiuretic hormone, but in the absence of it needing there to be. This is the syndrome that we call the syndrome of inappropriate ADH secretion. My time is too short to go too deep into that, but we all know it is caused by medication, by malignant disease, by pulmonary disorders, and by certain other infections of the nervous system. But mainly it is medication that causes SADH. There are some other probably more or less important physiological causes here, of which the most important one to mention is secondary adrenal insufficiency, and therefore in the case that you find a high urinary osmolality with a high urinary sodium, you should always measure cortisol, as this is a clear marker of that disease too. So it is quite easy actually. Again, I wrap up. Step one, start with the story. Is there volume depletion? What is the fluid and food intake? Are there reasons for SADH? What is the medical history, heart failure, kidney? That this delusional hyponatremia will be an easy diagnosis just by measuring glucose, for example, but there are some more rare causes that we have to assess. If the plasma osmolality is low, now we need to know whether there is ADH or not. We do this by measuring or by looking at urinary osmolality. Is it low? It is the polydiptic syndromes. Is it high? There is ADH. And then we proceed to the third step, which is the assessment of volume status. And the best way to do it is by using urinary sodium. Is it low? There is volume depletion. True or false? Is it high? There must be SADH, adrenal insufficiency, or some more exotic causes of hyponatremia. A small sidestep is that sometimes in the case of metabolic alkalosis, the urinary sodium is difficult to interpret, so therefore you can look at urinary chlorides to make the same step here. So step 3 in the case of metabolic alkalosis will not be assessing urinary sodium, but more looking at the urinary chlorides. Very important to order these tests already in the emergency department, because it changes in minutes from the moment you will start with therapies, and avoid, of course, diuretics before you will do urinary testing. A few more principles and common mistakes on hyponatremia treatments. I'm not going to dive too deep in this because it is written clearly down in the guidelines written by Spasowski and colleagues a few years ago. But the main thing is that from the moment hyponatremia has begun acutely, or there is a very symptomatic form, and severe symptoms are called vomiting, cardiorespiratory distress, deep somnolence, seizures, or coma, then you have to correct this as soon as possible within the boundaries of the numbers that we know. Do not correct hyponatremia more than 10 to 12 millimoles per liter per day, or in the first times a few millimoles over the first few hours. But again, watch out for this syndrome called central pontine middle lysis, which is kind of dangerous. But no matter that, severe symptoms need to be a treatment that is given acutely and urgently. When there are no symptoms, or the hyponatremia is more of a chronic problem, don't do it so fast. It's not that important. You have more time. There are a few very common mistakes in the treatment of hyponatremia. The first is forgetting to sample urinary biochemistry. Before you know what you're dealing with, you cannot start therapy. So you always need urinary biochemistry first, except in a few situations where there is really acute symptoms or where the diagnosis is really clear from the beginning, but that's not always the case. The second one, even more important, is that it is dangerous to blindly follow the Adrogema-Diaz formula that was published in New England many years ago, because when you do that, there is a certain risk to a too rapid correction. The formula is there in the upper right corner, and the point is that if you look at this formula, it will just treat patients like they were their own bags of water with certain compartments in there. But what the Adrogema-Diaz formula doesn't reckon with is that the kidney at a certain time will try to help you. So even when you calculate this very accurately, from the moment the kidney will contribute in the correction of hyponatremia, the correction will be much more faster than you prescribed or you calculated this in this formula. Of course, the risk factors for such a problem, for this too rapid correction, are young age, low comorbidity, because of course these patients have healthier kidneys that will deal with it from their sides. Second is polydipsia and hypovolemia. The kidneys are perfectly normal here, so from the moment you will be adding fluids or administering fluids, kidneys will help you and will tremendously fastly correct this hyponatremia. And the most important marker of a very fast correction will be a brisk early urine output. When you see that when correcting hyponatremia, you will know that the correction will go faster than you intend by calculating the Adrogema-Diaz formula. A third common mistake is ignoring potassium. We all know this equation on the right here called the Edelman equation or the Edelman formula that says that the plasma in the sodium is in proportion to the exchangeable sodium plus the exchangeable potassium divided by the total body water. What is extremely important to know here is that from the moment we are going to substitute potassium, this potassium will act like it is sodium just because of this formula. You can read the paper. Because of this formula, the sodium will increase as were the potassium that you are administering were sodium. So please think about that and correct it. And therefore, in the Adrogema-Diaz formula, the infusate potassium is at the same line as the infusate sodium. It will correct your sodium just by giving potassium. And the final thing or common mistake on hyponatremia is this one. We cannot or we are not allowed to overcorrect these patients. Again, we have to keep the correction rate within the 12 millimole per liter per day, or maybe one millimole per hour for the first few hours, but not faster. And a very common mistake is to have a too forgiving attitude for this overcorrection. It is even so that some clinicians are now trying to prevent this by giving desmopressin or ADH. What they do is, we call this technique the DJFAP clamp or the desmopressin clamp, by which we will put a clamp on the kidneys and avoid the kidneys to contribute in the correction of hyponatremia. We will give desmopressin, especially in this group of risk factors that I mentioned a few minutes ago. In these patients, you can give a little bit, for example, 2 micrograms of desmopressin, just to avoid the kidney contributing in this very fast correction. Also, when you see that the correction is going faster than you intend to, this is dangerous for this essential pontine myelinolysis. What is important there is that sometimes the symptoms of this syndrome are encountered much later, 3 or 4 days later. So it is not because you don't see a problem with a patient that there isn't one. And most of the time, this syndrome will kick in later. So when there is a too fast correction, you will need to reduce the sodium level again. And you can do this by giving glucose or dextrose 5% intravenously, or again, you can put a clamp on the kidney and give some desmopressin at a level of 2 micrograms, for example, to reduce a too fast correction. I think this is enough for hyponatremia. I will now advance to the next talk on hypernatremia. I see you in a few minutes.